Hello, can everyone hear me? Okay, good evening. Thank you everyone for coming today, making it here despite the cold weather and the rain lately. Um, I know I'm a new face, so maybe we can do a brief introduction. My name is Dr. Lana Shi. I'm one of the primary care physicians here at Torrance Memorial, so it's really nice to be here and be with you all today to do some fun learning. So today I'm going to be moderating our session on dizziness, balance disorders, and vertigo. These are three symptoms that are incredibly common, often very confusing for our patients, and sometimes very challenging for even physicians to distinguish. So today we are fortunate enough to have an outstanding panel of specialists who are also my colleagues, and they are going to help us break down the causes, the evaluation and management of these conditions. So these range from inner ear disorders to vestibular migraines to other neurologic and cardiovascular conditions as well. So our goal today is to provide some clarity for you guys on when is dizziness benign, when it signals something that could be more serious, and how we can better guide our patients towards the right diagnosis and treatment. So before we begin, I just want to put a reminder out there, please put your cell phones in silent mode. We will hear from each presenter at the end of the presentation program, and we will take a 2-minute break for you to jot down your questions. Or if you have jotted down your questions, you will see the Miracle of Living committee members passing out pens and paper to collect your questions. So at the end of the session, I'll go ahead and collect all the questions and address it to the panel. And if you're watching online as well, please jot down your questions in the chat, and those questions will be addressed as well. And then they did want me to mention that we had a really good turnout rate for today, and so we're actually out of slides. So if you are here and you did not receive slides and you would like them, please, you can find Mary Ford in the back and write down your email, and she will email you an electronic copy. Okay, great. So I wanted to introduce our first speaker, Dr. Alexander Gertel. He is one of our otolaryngologists here at Torrance Memorial. So Dr. Gertel received his undergraduate degree from the University of Southern California in biological sciences with a minor in sociology. He graduated from the Medical College of Wisconsin in Milwaukee, and went on to complete his otolaryngology head and neck surgery residency training at the University of Connecticut. Dr. Gertel grew up in Wisconsin, and since graduating from USC, he has always dreamed of returning to Southern California. His training kept drawing him further east, but he is excited to now be able to bring his knowledge and experience back to the West Coast. So please give a warm welcome to Dr. Gertel.
All right, good evening, everybody. So I've been with the group for going on four and a half years now, and welcome to tonight's event. So we will be talking about dizziness, balance, and vertigo. And so my role as an otolaryngologist or ENT, ear, nose, and throat physician, is to help with vertigo disorders specifically. So this is just a picture of the Casa Vertigo, which is an event space that is just right off the 10 freeway, just southwest of downtown LA. So as if I need any more reminders, every time I pass, this is a pretty prominent sign. But I always think of vertigo, and there you go. All right, there we go. So why would you see an ENT for vertigo? So the ear is divided into 3 parts. There is the outer ear. So that consists of the outer ear, the ear canal, and the eardrum. And that's where people might develop swimmer's ear. That's where earwax is made. Beyond that, deeper than that, behind the eardrum, there's an air-filled space called the middle ear. And there are 3 little bones that transmit sound to the inner ear. That's where people might develop the traditional ear infections or otitis media. And then beyond that, so even deeper than that, there's the inner ear. And the inner ear, if there's a problem in the inner ear, then that can cause vertigo. So the inner ear itself consists of two main parts. There's the cochlea, which is that snail-looking structure, and that is responsible for sound, where sound pressure waves are transformed into electrical signals that is transmitted to the brain through the cochlear nerve, and that's how we pick up on sound. And then attached to that, there is an organ called the inner ear labyrinth, and that consists of two parts. There's what we call the vestibule, and that consists of something called the utricle and the saccule. And then attached to that, there are three semicircular canals. And this is the organ that's really responsible for our balance and detecting motion. And so what that inner ear does for us is it picks up on our rotational movements. So whenever we shake our head, yes, that's the pitch. No is the yaw, and then kind of side to side is the rolling motion. So all those angular or rotational movements are detected by part of that inner ear. And then it also detects our linear movements. So it detects gravitational force. So vertical movements, like when you're on an elevator, it tells you that you're moving, and also horizontal movements, like when you're riding in a car. So vertigo, it's really a symptom, and it's a symptom of, classically it's described as room spinning sensation, or like your head is spinning, or the sensation of moving when you're not moving. And there are certain disorders that can cause this feeling of vertigo, but vertigo really is the symptom that these disorders will present with. Now, there are a lot of other ways that you can describe dizziness. So vertigo is just one of them. So vertigo, again, is that spinning or moving sensation. But sometimes people have a feeling of lightheadedness, or they feel like they're going to faint, or they just feel weak, or they feel like they're going to fall, or they might have brain fog. So, all of these sensations, we kind of group together and say that we feel dizzy, but it is important to distinguish what you're feeling, because that can help us figure out what is going on. I mean, really, true vertigo that's coming from the inner ear, again, classically is really like a spinning or moving sensation. If it's really just lightheadedness or just feeling weak or brain fog, that actually usually is not coming from the ear. So what could it be coming from? Well, that's what makes this complicated. There are so many different causes of dizziness, and ear problems are only just one thing that can cause dizziness. So of course, in my world, in the ear world, there's ear infections. We're going to talk about a number of the different types of vertigo, but there can be a lot of neurologic causes. So scary things like stroke, brain tumors, multiple sclerosis, Parkinson's, other things like that. It can be a cardiovascular issue. So maybe someone's dehydrated, or maybe their blood pressure is not well controlled. Heart arrhythmia, like atrial fibrillation. So narrowing of the carotid artery as it brings blood up to the brain. And then there are lots of other things that are, electrolyte abnormalities, anemia, any type of, infection, low blood sugar. All these things can cause dizziness, and that's what makes it so complicated and so frustrating. And a lot of people end up seeing a lot of different doctors to figure out what's going on. So you might see your primary doctor. If someone might go to the emergency department if they're not feeling well. They might see an ENT, a cardiologist, a neurologist. And so sometimes it can take a lot of work, and it can be very frustrating to figure out what exactly is causing dizziness. When I'm trying to figure out if somebody has vertigo, there are some important characteristics that I always ask about, and that really helps me hone in on, is this person having a vertigo issue related to the ears, or could this be something else going on? So we already talked about what is the sensation. So we're trying to really distinguish, is this more of like a moving, spinning sensation, or is it something else? So that's one factor that I look at. Another thing is, how long does the vertigo last? Is it something that just lasts for seconds to minutes and then you feel better for a while? Is it a feeling that lasts longer, minutes to hours? Is it a constant feeling that can last days or weeks? Also, how frequently does this occur? Is it a daily thing? Is it monthly? Is it just once in a while? Position is important. Sometimes changing your position, different movements can trigger the vertigo. So are there certain types of head movements? Is it rolling over in bed? Is it bending down? Is it reaching up to get something off of a high shelf, or putting in your eye drops, or washing your hair? Things like that can trigger. And so that's another important factor. And then also hearing changes are very important. So some types of vertigo can also come along with actual hearing loss, or ear fullness, or maybe a ringing of the ear, which we call tinnitus. But some forms of vertigo have no hearing loss at all, no effect on hearing. And the reason why they might, again, because if you remember the anatomy, the cochlea, the organ of hearing, is attached to the organ of balance. And so sometimes there are things that can affect both. So in diagnosing vertigo, it can be challenging, and really a lot of times we are relying mostly on your symptoms. So again, all the things that we just talked about, what is the feeling and when did it start? And so symptoms is one of the main things we look at. So a lot of times it's just like a diagnosis based on your history. There are certainly some physical exam findings that we can find in the office. So there are certain movements and maneuvers that I can do that might induce the vertigo. And then one of the other cardinal findings of like a true inner ear vertigo is this thing called nystagmus, which is this very characteristic eye movements where the eyes just start bouncing uncontrollably, usually to the side or up or down. And so that's usually one of the cardinal signs that we see on physical exam, is if we can induce the vertigo, is there also this nystagmus, this abnormal eye movement going on. But in general, there's really no blood tests, there's no biopsies, and a lot of times we don't even really rely on any imaging studies to diagnose vertigo. There are some other ancillary tests, so if there's any hearing loss or anything, then it's good to get an audiogram, which is the hearing test. There is some testing that can interrogate the inner ear balance system. That's called a VNG, or video nystagmography, where it's looking at the reflex between the ear, the brain, and the eyes. And those things are done with an audiologist. And sometimes we'll do an MRI, and if we really can't figure out what's going on, or if we're more nervous about other things than vertigo. And so we'll go through some of the common vertigo disorders that I see. So the most common disorder is called benign paroxysmal positional vertigo, or BPPV. This is your classic. I think if you think of vertigo, this is what most people think of. So this is the type of vertigo where if you roll over in bed, or bend down to pick something up, or reach up to get something from a high shelf, or throw your head back, you might get the spins for seconds, maybe a couple of minutes, and it's very uncomfortable and can make people nauseated. But after a few seconds, it goes away, and then doesn't happen again until the next time you do this motion. And so again, the sensation is usually severe room spinning, but it's brief, it's seconds, maybe a few minutes. And it happens frequently whenever you do that movement. Now, usually this is self-limited and can last 4 to 6 or 4 to 8 weeks. But if someone has this disorder, it can sometimes happen once a year. So every year they get their vertigo. We talked about the different position or head movements, but importantly, there are no hearing changes with this. So while the vertigo is happening, there's no change in hearing, and it doesn't cause any hearing loss at all. And how do we diagnose it? So again, clinical history, the story, listening to the symptoms, and then this type of vertigo, while it's active, we can actually induce this in the office. So by kind of laying someone down with their head tilted back, people will get dizzy, and I can see that eye movement. So you may have heard about these crystals in your ears. Like, what are these crystals? So yeah, your ear actually does have crystals. Now, these crystals are very small. They're microscopic crystals made out of calcium or calcium carbonate, and this is part of how the inner ear picks up on movements. So these crystals are really called otoconia, and they live in the vestibule part, the part that senses your linear movements, the horizontal and vertical movements. This is a really magnified view of what they look like, and they're resting in this like layer of gel, and whenever you move, the gel kind of shifts, and those little crystals provide that gel some weight, and it causes a whole chemical cascade, which your brain interprets as movement. But we think that the reason why this benign positional vertigo happens is because these little crystals get either displaced or they degrade, and they fall into these semicircular canals, the part of the balance system that controls your angular or rotational movements. And so now they're floating around where they're not supposed to be. And whenever you do a rotational movement, it tricks your brain into thinking that you're moving faster than you really are. And so you get this extreme sensation of spinning with those certain movements. So it's lifetime prevalence, 1 in 40 individuals may experience this throughout their life. It's more common in the 5th to 7th decades of life. It has a little bit more of a female to male prevalence, so more common in women, but definitely happens in men. And unfortunately, about 15 to 18% of people might have like a recurrent episode every year. So how do we treat this really common type of vertigo? So again, sometimes it can just be self-limited. It might last for a few days, it might last for a few weeks, but it sometimes will go away. And maybe one of the reasons for that is either those little crystals dissolve on their own, or somehow they find their way back into the right place, or your brain just gets used to it. But there are some really helpful exercises that can help to reposition those crystals and put them back into place. So the most famous one is called the Epley maneuver, which I can do in the office. Our physical therapists are also very good at it. Sometimes people get better with just one exercise. Sometimes it takes a few, but it is also something that can be done at home. And if it's not getting better quickly with just a couple of exercises or at home, then vestibular rehab or physical therapy for vertigo can be very helpful for this. So there's some more recent research that links this type of vertigo to maybe some calcium disorders. So there's been some studies that have shown that there are higher rates of this type of vertigo in people who have vitamin D deficiency. And in fact, there was an interesting study that showed in like northern climates, the most common time people came in with this vertigo was in the spring, after they were cooped up indoors all day and they weren't getting any sunlight, they weren't making in vitamin D. And it's also more common in people that have osteoporosis or osteopenia. Even up to 75% of people with this type of vertigo might have osteoporosis. And so it's more common. Now, we're not really at the point where we can recommend, well, if you have this type of vertigo, you should supplement with calcium and vitamin D, but it might be a good idea that if someone does have this type, maybe get checked their vitamin D levels, calcium, get checked for osteoporosis. All right, so this second type of vertigo that I see somewhat frequently is actually two different disorders, but they're very similar. So one of them is called vestibular neuritis, and the other one is called labyrinthitis. So this is a type of vertigo that starts suddenly and spontaneously. You might wake up in the morning and then try getting out of bed and just very dizzy. Everything is spinning, cannot even walk, very nauseated, can like barely crawl to the bathroom. And it comes on suddenly. So it's a severe room spinning sensation. The thing is that it feels terrible, but it can last for hours, days, and sometimes it can linger. It usually gets better, but linger for even weeks. But it's a sudden onset, it's a constant feeling. It does gradually get better, but your balance might be even impaired for even months after this disorder. Movements will worsen it. It's not necessarily triggered by movements, but if you're doing certain movements and rotating and rolling, then that makes it worse. And during the course of recovery, it might start to behave like the benign positional vertigo, where it only bothers you if you're in certain positions. So the difference between these two disorders, vestibular neuritis and labyrinthitis, is that one of them, vestibular neuritis, does not have any hearing changes. It's just the vertigo. Whereas labyrinthitis affects that whole inner ear labyrinth. So not just the balance part, but also the hearing part. And so when someone just develops like this sudden onset vertigo, if they have labyrinthitis, they will also have hearing loss. Usually it's just in one ear, but they might not be able to hear at all. And they a lot of times have a lot of very loud ringing or tinnitus in the ear. And how do we diagnose this? So again, it's a lot of just clinical history, symptoms. We certainly see the vertigo and those abnormal eye movements in the office. There's some other exercise or movements that we can use to confirm this. If there's any hearing loss, it's very good that we get an audiogram or a hearing test. And a lot of times, when people get these types of disorders, it's very scary. I mean, it's sudden onset, severe dizziness. A lot of people end up in the emergency room to rule out things like stroke. And so it's not uncommon for people to get an MRI to look at the brain. But in my patients, if they're really just not getting better, they're only slowly improving, then I usually will end up ordering an MRI also, just to make sure we're not missing anything. But someone with labyrinthitis, if it's just the vertigo, there actually aren't any findings on everything. The brain looks normal. So how do we treat it? Again, this is another thing, the tincture of time. So it's self-limited. It usually does get better on its own. Supportive care, that means that there are a number of different medicines that can help people feel better. They really just more mask or treat the symptoms. They don't really treat the underlying cause. And so there are things like meclizine, Benadryl. Sometimes we'll use medications like Valium. All these things suppress the inner ear system and can help just the symptoms feel better. Anti-nausea medication. So steroids. So usually, if we catch this early on, steroids like prednisone can be helpful. And the reason is we don't fully know what causes this type of vertigo, but the most prominent theory is it's some sort of inflammatory disorder of the inner ear. Because oftentimes it might happen days or weeks after someone has a cold or COVID or any type of virus. And so we think it's this inflammatory event affecting the inner ear. And so steroids, which are really powerful anti-inflammatories, can really help. The data isn't super strong, so it's like kind of 50-50 that steroids are really going to help, but really they can help people feel better quicker and sooner. But whether someone gets steroids or not, they're still going to end up getting better in the end. Another important thing to do is to try to do early physical activity. Movement helps, just because we want our brain to adapt to the abnormal signals it's getting from the inner ear. And going along with that, vestibular rehab or physical therapy can also be really important and helpful to get your balance back. All right, next disorder that I see is something called Meniere's disease. So this is pretty rare. It really, like the figures, it's like 0.19% of the U.S. population. But this is a disorder that we think either occurs because there's too much fluid within that inner ear balance system. That's the classical theory. And then the newer theory is that this is actually might be a form of a migraine. But this is a disorder that presents with vertigo and hearing loss, and it actually causes real hearing loss. Actually, just to back up for a second, for the previous disorders with the hearing loss, the majority of people with this labyrinthitis, they actually will regain their hearing. So hearing usually does come back. Not everybody, but definitely more than half. Whereas Meniere's disease actually causes a real permanent hearing loss. So this is a disorder that is characterized by these severe room spinning attacks that just happen suddenly. You just feel super dizzy, nauseated, and just really feel like you have to lay down. And these attacks last anywhere between 20 minutes and 24 hours. They're unpredictable, don't know when they're going to happen. Position doesn't cause it to happen, but there are definitely hearing changes. So during these vertigo attacks, one ear can feel like it's full. It actually does cause a permanent hearing loss over time. There's a lot of ringing, and usually it affects one ear. It could affect both ears, but usually it's one ear. Again, we talked about, is there too much fluid? Is it a migraine-like disorder? Again, the diagnosis is, the history, the symptoms, getting a hearing test to see if there are any hearing changes. So there's a number of ways to treat this. So in the acute setting, things that might make people feel better, similar to what we discussed about labyrinthitis, is steroids, like Valium, Meclizine, Zofran for nausea. But long term, again, the classical theory about this disorder is that it's a disorder of too much fluid in the inner ear. And so a lot of the treatments that were developed were trying to decrease that fluid, get rid of fluid from the body, or improve fluid flow in the ear. So low sodium diet, really only 2 to 3 grams of sodium per day, help to decrease blood pressure. There are certain diuretic or water pills that we use. There's a medication that's not really used much anymore. You can get this. It's actually not even really available in the United States except for compounding pharmacies, but they sell it all over the world, called beta histine. That can be helpful. Physical therapy has a part in this to just help with balance. And then this is really maybe the only type of vertigo that can improve with surgery. So first of all, even before surgery, there are injections that can be done in the ear with steroids that can help. There's an antibiotic that can be injected into the ear that helps. And then surgeries involve creating a little shunt in the inner ear to draw off the fluid. The risks of these things, though, are that they can cause permanent deafness in that ear that you're treating. And so really these things would not be considered at all unless someone was suffering from this, we had no other treatment, and there was already hearing loss. And I'm going to talk about this briefly because I think Dr. Ueng is going to talk about this. But going along with the Meniere's being maybe a migraine, migraine can definitely cause like vertigo and dizzy symptoms. And so just briefly, room spinning sensation, or it might even just be very nonspecific. Someone might have had a history of migraines in the past, or they still do. A lot of times it'll develop, it'll come along with light sensitivity, sound sensitivity. There might be an aura, seeing different colors in the eyes before it starts. And it doesn't really, the most important thing is that it does not have to have the migraine headache. And so, so even more than 50% of the time, it's just dizziness and vertigo. It's not even a headache. Now, these usually can last for minutes to hours, again, intermittent. But a lot of times there are also hearing changes. So ear fullness, ringing, sound might start sound distorted, but it doesn't cause any true hearing loss or permanent hearing loss. And a lot of times it's both ears that are affected, not just one. Again, there's clinical history following the symptoms to try to make the diagnosis. It's also more common in people who suffer from motion sickness for most of their lives. So there are a number of things that we do to treat migraines and Meniere's disease. There are a lot of triggers that if we can try to avoid them or understand them, might improve things. So trying to avoid stress, certain hormonal changes, especially associated with the menstrual cycle, can trigger these things. Bright light, sound, visual motion, scrolling on a phone or a computer screen for a while. A lot of things can trigger these. And there are a number of things that we can do to prevent this from happening. And so you see that these types of disorders, there are a lot of other treatments, a lot of treatments for them. And so there are different vitamins like magnesium, vitamin B2, trying to stay hydrated, not skipping meals, and there's a whole list of foods that can be triggers for people. They're all good foods, by the way, if you notice. And then, but also importantly, sleep is important. Getting good, consistent sleep, which is also sometimes a tough thing to ask. There's a lot of medications that can be used to treat migraine. Okay. And then also, I think we're going to talk about it a little later too, but the next type of vertigo is this long name, so persistent perceptual postural dizziness, or PPPD, or triple PD. This is a little bit of a newer diagnosis. So there are a lot of people that have a lot of these symptoms of swaying, dizziness, unsteadiness, swaying. They might feel lightheaded, maybe some spinning. They have different difficulty concentrating. They feel anxious about the symptoms, but they don't really fit with anything else. So it's almost like a diagnosis of exclusion, which means that we kind of ruled out everything, and we really didn't know what to call it before. But so this is a bit of a newer diagnosis. A lot of times it is triggered by an episode of vertigo, or if someone was having a balance issue or a very stressful event. But it's really characterized by a constant feeling, all these sensations that are that are worse when standing, when walking, in a very busy environment, like in a grocery store, and there's lots of lots of things in the aisles, and it feels better, and you feel better when you're sitting or laying. There's no changes associated with it, but this is a tough one. This is a tough one to diagnose. A lot of time based on the history and but the physical exam. So can't induce any vertigo, can't induce the eye movements. If we do a hearing test, it's completely normal. If we do the balance test, it's completely normal. And MRI, all normal. So we have to rely a lot on our history. I think we're going to go through this a little. There's a number of things that can be done to help treat this, which I think we're going to talk about soon. And then the final thing that I want to talk about is the thing that may be the most serious, so to speak, and the reason why we'll sometimes get an MRI for someone with vertigo. So there's a benign, so it's benign, but there's a benign tumor that can develop from the cells that insulate the hearing and balance nerves called a vestibular schwannoma or acoustic neuroma. And when these grow, they can put pressure on those nerves and can cause both hearing loss and vertigo. Now, it's more common for this to present with hearing loss than just vertigo, but it is another cause of vertigo. So it's a benign, slow-growing tumor in what's called the internal auditory canal. That's the channel that those nerves pass through as they go to the ear. It is pretty rare. Only about 1 in 100,000 people will discover this in. But usually the symptoms might be a sudden hearing loss and vertigo. Usually the hearing loss is just one ear. Usually this affects just one ear at a time. And it also might cause facial palsy or paralysis, because one of the other nerves that travels in that same region is the facial nerve that controls the facial movements. Usually once these symptoms start, they're persistent. Sometimes they get a little better, but they come back and there's exacerbations. Talked about the hearing loss, usually one ear. And the diagnosis, what leads us to diagnosis is usually the first thing we get, especially with the hearing loss, is the audiogram or the hearing test. And that might look like this. I don't think you have to be a doctor to know that there's a big difference here and there's something abnormal. So what this hearing test is showing is that here's the left side, so hearing's okay, and then maybe the high frequencies, like the higher pitch, so maybe some age-related hearing loss, in this left ear. But the hearing on the right ear is vastly different. And so if we see asymmetric hearing like this usually will trigger us to get an MRI, and then that can help us make the diagnosis. So this is actually an image from one of my patients. So this is an MRI, and this is the right. So the right side, you have this here. This is where the hearing nerves travel to the cochlea. So if you can see on this side, you can kind of make out that cochlea and the semicircular canals, and here are the little nerves on the left side. But on the right side of the patient, which is the left side of the screen, you've got this mass here. And so there are a lot of different ways that this can be treated. If they're actually small, because they're benign and slow growing, sometimes we can just observe them, especially if they're not really causing any significant symptoms, and just get an MRI every 6 months or a year, depending on how far out we are. There is special radiation therapy for this, like very targeted, like Gamma Knife or CyberKnife, and there is surgery. But the surgery to remove this, it's neurosurgery. It's usually done in combination with an ENT and a neurosurgeon, but it is a real neurosurgery if we have to go kind of into the brain, and so it is a big deal. So in summary, vertigo is a common cause of dizziness, but to be more precise, it's usually described as a room spinning sensation. And so we have to differentiate between vertigo that's coming from the inner ear, or is it again hundreds of other causes of dizziness. The diagnosis is mostly clinical, based on the history and the physical exam. Usually there are no blood tests, biopsies, x-rays, CT scans, MRIs, all those things, if we really suspect it's from the inner ear. But there is some testing that may be helpful, like hearing tests and the VNG, which is the balance test. And then if we're really worried, MRI, we do that. The good news is with vertigo is that people generally will get better. You will get better. It feels terrible while it's happening, but all these things are usually self-limited, and with time, people get better, especially if they start getting active again and help the brain adjust to the abnormal signals that it's getting from the inner ear. There are things that we can do to manage the symptoms, so various medication to help with nausea. again, for some disorders like Meniere's disease and migraine, there are lifestyle changes, medications, diet, things like that. Very rarely do we do surgery, maybe only for Meniere's and the acoustic neuroma tumor. And then really a cornerstone of the treatment that works very well, and we'll find out more soon, is physical therapy, or we call it vestibular rehab therapy, can be very helpful in treating these disorders. So thank you very much, and hope you learned a few things and enjoy the rest of the evening.
Thank you, Dr. Gertel, for the very informative lecture. How many people in this room have experienced dizziness at one point or another in their lifetime? Okay, that's like, what, 70, 80%, and I'm sure there's more people at home. So just to offer a little bit of primary care perspective, I see dizziness very commonly in primary care settings. And so one take-home message that I kind of wanted to give for you all is, like Dr. Gertel had mentioned, there are a lot of causes for dizziness. So the history from you guys is really important for us to help figure out what's going on. So when you come to see us, it's helpful for me to know, is the dizziness, is the room spinning? Are you lightheaded and fainting? Or is it more you have brain fog and you feel weak? Because that's gonna help me know which specialist to send you to help you get the right diagnosis. And the other thing too is specifically for ear, nose, throat conditions, it would be helpful to know if you have hearing loss or any ringing in the ears. So keep that in mind when you go see your doctor. These are some important symptoms to report to them. Okay, so with that being said, I wanted to introduce our next speaker, Dr. William Ueng. He is a board-certified neurologist who subspecializes in neurophysiology. He received his undergraduate degree in biochemistry at UCLA. Before going into medicine, he decided to pursue a broader understanding of health and received his master's degree in public health at Columbia University. He then earned his medical degree from the University of South Florida. He completed his internship at UC Irvine Medical Center before completing his neurology residency and neurophysiology fellowship at UC San Diego Medical Center. Dr. Ueng is passionate about all aspects of neurology and has particular interest in neuromuscular disorders. He values patient education, open communication, and longitudinal care for his patients and their families. And in the future, he hopes to continue his work in medical education and training of future neurologists. Thank you.
Alrighty, so my name's Will, Dr. Will Ueng, I guess, and I'm one of the new neurologists here at Torrance Memorial Medical Center. I actually just started in September, so I'm very new here. I'm excited to meet you all, and I just wanted to first thank you for this opportunity to speak with you, and I hope you learn a little bit about what we're going to be talking about today. Before I get started, I just wanted to say thank you, Dr. Gertel. I feel like I don't have to speak. I don't have to talk about anything because he covered it all, basically. So it's going to be a little bit repetitive today, I think, but this is good to kind of recap and just kind of go over things again to make sure it locks in our brains. So the title of my talk today is Vertigo, What's Making Me Dizzy? So first off, I have no disclosures. And so the goals of our talk today, basically today I'll be talking a little bit about the common causes of vertigo, then we'll go over some of the common treatments of vertigo, and then we'll talk a little bit about what is an emergency and when might I need to go to the emergency department. So, like Dr. Gertel had mentioned, when someone comes in to see me for dizziness, I first need to figure out what are they actually experiencing. So are they having something called vertigo, or are they having something called presyncope? And so this is very important because based on what you say and what you describe, we're going to be going down very different routes of evaluation. I understand that dizziness is very hard to describe, but like Dr. Gertel was mentioning, I'm trying to figure out if you have something like unsteadiness, like you're on a boat, if you're feeling like the room is spinning, which is what we call vertigo, or if you feel like you're lightheaded, like feeling like you're going to pass out, which is something called presyncope. And this is important because, like I said, depending on what you tell me, I'll kind of be thinking about different things and guiding you down different routes of evaluation. And so when it comes to vertigo, or that feeling of being on a boat or the room spinning, there are really two broad areas that can cause vertigo, which we split into the peripheral causes and the central causes. This whole system together is what we call the vestibular system, and it's what keeps you in balance. And so this is another picture of that. So the peripheral causes of vertigo include the ear, the inner ear, the nerve that controls the ear, and then the central causes of vertigo is the brain itself. So we're trying to figure out where along that line is there an issue to figure out how we can best help you out. So a few of the common causes of vertigo. We already talked a lot about a few of these with Dr. Gertel, but to kind of recap, we're going to be talking a little bit about benign paroxysmal positional vertigo, or BPPV. We'll talk a little bit about vertiginous migraine. We'll talk about acoustic neuritis. We'll talk about Meniere's disease. We'll talk about something called vertebro-basilar insufficiency, which is a big fancy term, and stroke. And then we'll also talk about tumor. So when it comes to figuring out the cause of your vertigo, it really kind of depends on the history and physical exam. So we'll talk to you to try to figure out what kind of symptoms you're having, and then we will examine you to try to figure out if this is more of a peripheral cause, or issues with the ear, the inner ear, or the nerve itself, or is this more of a central process, meaning issue with the brain. So for the first cause, we'll talk a little bit about BPPV. So this is the benign paroxysmal positional vertigo. This is the crystals in the ear that Dr. Gertel was talking about. And it's basically a condition where those crystals in your ear are getting stuck in different parts of the inner ear, and it causes the vertigo. Typically, when I talk to my patients, I'll hear about the symptoms lasting for seconds at a time. Head movements will make it worse. I will often hear that my patients tell me that it's worse when they're in bed, moving their head around, and that they feel like very concerned about moving their head because it'll trigger the dizziness. When it comes to things like vertiginous migraine, which is basically vertigo that occurs with migraine, like Dr. Gertel was mentioning, it doesn't always have to have migraine along with it. I will hear patients have vertigo before the migraine, with the migraine, after the migraine. It really can happen at any time. So this is something that I am very careful about evaluating for to make sure that I'm not missing it. Basically, usually I'll hear that the symptoms last for hours at a time, and it'll be episodic, meaning patients may have it today, they may have it tomorrow, they may have it next week, but it comes and goes. We also talked a little bit about similar things like this. So this is something called acoustic neuritis, which is basically inflammation of the nerve that controls hearing. And so the symptoms can typically last for days. This is very similar to the vestibular neuritis that Dr. Gertel was mentioning. But basically, the suspicion is that after an illness, like a cold, a cough, a fever, it triggers an inflammatory response in your body, and then you get some leftover inflammation of the nerve that controls the ear. And so I'll typically hear that the symptoms last for days, and may have sometimes issues with hearing along with it. Dr. Gertel also mentioned a lot about Meniere's disease, which is a condition suspected to be like a buildup of fluid in the ear. And usually it'll last for minutes to hours and be episodic also, meaning it comes and goes. And I'll usually hear about ringing in the ears along with this, or even ear fullness. So I wanted to spend a little bit of time on this. So there's also other ways that you can have vertigo too. These are two different conditions. So there's one that I'm going to call vertebro-basilar insufficiency, and then I'm also going to talk about stroke. So in your brain, there's a few blood vessels that kind of supply the back part of your brain. It's your vertebral arteries in the back that connect into something called the basilar artery. And so with vertebro-basilar insufficiency, this is basically a situation where those pipes are a little bit tight, meaning that you'll have a little bit less blood flow to the back parts of your brain. This will cause things like the vertigo, that room spinning situation, and you may also have other symptoms along with this too that seem very similar to a stroke. So things like double vision, trouble chewing or swallowing, weakness in the arms, numbness in the arms and legs, trouble walking, all these sorts of things. And then the more severe version of that is when you actually have a stroke, which is a lack of blood flow to that back part of the brain. So then again, you will have symptoms of double vision, trouble swallowing, speaking issues, or weakness. Depending on what it is, it may happen all of a sudden, and it may be persistent after that. And then we have something called an acoustic neuroma, like Dr. Gertel was talking about, where there's a tumor of the nerve that controls hearing. The typical symptoms will last for days, and patients may also have issues with hearing. And so, along with the history and physical, we may do a lot more testing to try to figure out the causes of your vertigo. Depending on what I'm hearing, depending on what I'm seeing on your physical exam, we may do an MRI of the brain to look for things like the tumors or things like strokes. We may sometimes look at the blood vessels of the brain to see if there is tightness of those vertebral arteries or even the basilar artery. And we may even do hearing tests depending on if you have associated hearing loss with it. And so when it comes to the treatments, really we want to figure out first why you're having the vertigo before we then talk about treatment. We want to make sure we're targeting our treatment to the specific types of vertigo that you might have. So Dr. Gertel went over a lot of these different things here, but there's specific maneuvers that we can do to kind of flip-flop you around, get the crystals back in the right place for BPPV. There's certainly a lot of different kinds of migraine medications that we can try. Oftentimes we'll talk a little bit about prophylactic treatment, meaning medications that you take every day or on a regular basis to decrease the frequency and severity of these episodes. And sometimes we will talk about abortive treatments, meaning medications you take to try to kill the symptoms when you're having it. With things like this acoustic neuritis or vestibular neuritis, which is the inflammation of the nerves, we may try steroids to try to calm down that inflammation. When it comes to things like Meniere's disease, there's certainly many medications that we can try to decrease the fluid or even those surgeries that Dr. Gertel is mentioning. When it comes to things like stroke, there's certainly stroke treatment and stroke prevention to make sure it doesn't happen again. And then when it comes to tumor, there's certainly surgeries and different tumor treatments along with that too. And then so we come to a medication called meclizine. So this is a medication that kind of calms down the vestibular system in general, but it doesn't necessarily get at the root cause. This is a helpful medication to help out with that symptom of that room spinning situation. And it's a medication we often prescribe to help out with their symptoms while we're getting that evaluation, try to get to the bottom of this. Dr. Gertel also mentioned a little bit about the Epley maneuver, and I think we might hear a little bit more about it, but basically this is for the BPPV, which is the abnormal crystals getting stuck in your inner ear. And so when we're doing the evaluation, we first need to figure out, A, is it BPPV? And then B, which side is it? So we got to figure out which side's going on so that we can flip-flop you around in the right way to get the crystals into the right place. So this is certainly something that we can do in the office. We sometimes give you like printouts to help do it at home. People can do it with vestibular physical therapists also. This is a great way to kind of flip-flop those crystals back into the right place. Sorry. Lastly, I kind of want to talk a little bit about when should I go to the emergency department. And so there's a few things that you want to pay attention to when you're thinking about vertigo and when you might need to go to the emergency department. Really, the main things I would look at is, did the symptoms occur all of a sudden, or do you have other symptoms of a stroke along with it? Things like double vision, weakness, numbness, trouble swallowing, trouble speaking, facial droop, any of these things, if you have it along with that kind of room spinning situation, straight to the emergency you go. Call 911 and get to the hospital. These are the red flags because we're looking for a stroke, is basically what we're looking for. And certainly when people have these sort of symptoms, we want to treat them for stroke. There's certain medications that we give in the short time period when these things happen to help treat those symptoms. So if you feel like you have any of those symptoms, call 911, go to the hospital. And so here's another example of that. So this is a nice little acronym that Torrance Memorial has. So it's something called B FAST. So B is for balance. So if you have that kind of room spinning sensation, feeling unbalanced. E is for eyes, if you have sudden loss of vision in one eye or both eyes. F is for face, so if you notice any sort of droopiness of the face. A is for arms and legs. So if you have any weakness or numbness of all of a sudden in the arms or legs. S is for speech, so if you have any issues with getting the words out or if you're having slurred speech. And then T is for time, meaning you should call 911 very quickly. And all that to say is that we're here to help. Vertigo is definitely an uncomfortable sensation, but there are definitely many options when it comes to the diagnosis and treatment. And so we're here to kind of help you sort through it all. And that's it for me.
Thank you, Dr. Young. As you were talking, I actually had the thought that maybe it would be informative to demonstrate an Epley maneuver. I'm happy to be. What are your thoughts? I'm happy to be the practice patient, and I think it could be helpful. Are you all familiar with how to do the Epley maneuver?
The only thing I would suggest is for them not to do it themselves at home.
Okay.
Maybe we'll show them what we do,
Okay.
but not to do it at home on your own.
Okay, got it. Do you guys want to, are you interested in seeing how we would do an Epley maneuver in the office? Okay, so I'm happy to be the practice patient if somebody wants to do it on me. And sorry for the folks at home if you can't see it, because we'll probably try to do it over here. Okay.
You want me to do it now, or do you want me to do my talk and then we'll do it?
Yeah, that would be fine.
Whatever you want.
Maybe it would be, we could wait until after your talk, that way we can see, we can get some background information, and then we'll do it at the end of the talk before we go into questions. Okay, great. So this brings us into our next lecture from Noelle Budrovich. She is a licensed physical therapist, a doctor of physical therapy. She is a certified strength and conditioning specialist and earned her certification in vestibular rehabilitation from Emory University. Practicing in the South Bay for 35 years, specializing in vertigo, dizziness, and balance. Thank you. Please give a warm welcome.
Should be 44%. Feel free to talk. I'll just get it up there.
Okay. Kevin's helping me. We had a little technical issue, not user error, just Kevin's helping me out here a little bit. My part of the lecture tonight, yes, I'll have some things in there about a lot of the things are repetitive to what our wonderful doctors here have talked about. But I'm going to kind of call an audible and throw some other things in there just to give you a perspective more from a physical therapist. I'm going to get closer to that microphone in just a second. I know you're putting your hands on your ears. You'll hear me in just a sec. Okay. Okay. There we go. Thank you. Okay, I'll just do here. Oh, okay. So again, my name's Noelle. I actually started here back in the 90s, the first part of my career, and I'm after 22 years back to finish my career here. So I'm happy to be back at Torrance Memorial. So part of what we're talking about tonight is the doctors did a great job talking about the causes, more the medical side of it. I'm going to talk to you more about the rehab side of balance, vertigo. So let's go into here. There we go. So, we talked about dizziness and balance disorders are a common reason for physician visits for people over the age of 75, affecting 20 to 30% of our population. 35% of adults over 40 have vestibular dysfunction, and as the doctors described earlier, it's a disturbance in the body's balance system from the vestibular or inner ear, and or from the central or brain. Unfortunately, 75% of those with balance fault issues have vestibular dysfunction. So even though you might be having balance issues, there could be an underlying vestibular issue. So it's good to have that checked out. I know the doctors talked a lot about this. I won't go into detail on this, but we talked about the vestibular and neurologic, also some cardiovascular issues, why people might be having dizziness, as well as systemic issues. So it's good to make sure you're talking to your doctor about that, so they're ruling out all the possible causes of vertigo or imbalance or dizziness, as opposed to WebMD, right? So dizziness really is a descriptor. In vertigo, we talk a lot about like the room is spinning, I'm feeling dizzy. Lightheadedness would be a little bit more of some wooziness, fainting. We talked about that lightheaded feeling. And disequilibrium, unsteadiness on your feet, imbalance, often without the sensation of movement. I see a lot in my practice, in our practice here at Torrance, about those words get mixed up a lot. A lot of people come in, I'll have people come in with diagnosis of vertigo or dizziness, but maybe they're really, and I'm not going to say just as in that's not as important, but maybe they're just out of balance. They have that sensation of being imbalanced, they're feeling unsteady, but they keep calling it dizziness. And sometimes those words get really blended together, and it can be a little, it can send doctors down paths that are good paths to go, but maybe it's not getting the answer you need. So it's really good, as the doctor earlier described, be specific in what you're feeling. Are you feeling spinning? Are you feeling unsteady on your feet? One of the things I'll look at with people as I'm going through, it's not this, we're checking the boxes. I'll ask them, are you feeling dizzy when you're sitting? No, not at all, I'm fine. How about when you stand? Oh, I'm fine unless I'm holding onto the grocery cart. If I'm not holding the grocery cart, I'm really dizzy. So you kind of go, all right, how are you dizzy standing and not holding a cart versus standing and holding the cart? So maybe that's not dizziness, maybe that's imbalance. So you see how some of those words can really get blended together. So it's kind of good to kind of pick it apart a little bit when you are talking to your doctors, so you can be a little bit more specific instead of, I'm dizzy. And now you've been through 5 doctors with, I'm dizzy, and they can't find what's wrong with you, right? So just to kind of be a little more specific in what's going on, just kind of pay attention. But I see that a lot. So as the doctors have talked about, history is truly key. It's really important for us to be able to get down and find out the specifics. What are you feeling? What are you experiencing? What positions are you experiencing that in? How long is it lasting? How long have you had it? Excuse me. Are you seeing any patterns to it? We talk about hearing loss, other associated symptoms with nausea, vomiting, headaches, heart palpitations, all the different things that have already been mentioned tonight. Precipitating events, a recent illness, a trauma, blow to the head, which can also cause a benign positional vertigo, which we'll get to, and medical history, as we talked about, different systems at the bottom there. And then we've also discussed the vestibular system, your outer ear, your middle ear, but your inner ear is where that balance and hearing system is. I think the next slide will show a little bit more. So getting into that balance part of that inner ear, our body uses 3 systems to maintain balance. We use our visual system, we use our inner ear balance mechanism, and we use our proprioception, or our awareness of movement in space. So if that's looking at your inputs, your vision, your ears, that rotation, translation, gravity, your inner ear, your eyes, your inner ear, and then pressure, that feeling of the ground underneath you. When those 3 systems work together, the outputs are great. You got balance, you're seeing what's going on, everything's good. If you have one of those 3 systems that isn't quite functioning properly, it certainly can affect your balance, whether it's dizziness or balance itself. So having all of those working together really makes a difference. As we have more birthdays, they don't all work the same. Our vision isn't as good. Maybe you don't feel the floor as well with your feet. For many different reasons, we can have issues with that. But it's important to be able to keep working on your balance to help maintain your upright position. So what is vestibular rehab? So under our physical therapy umbrella, We have this, so these are some of the programs we offer here at Torrance Memorial. We have vestibular rehab, we have a neurologic, lymphedema, orthopedic, pelvic health, and pediatric. In our vestibular rehab, we specialize and treat symptoms that are caused by vestibular-related dizziness. Our clinical exam is super important for us to be able to see the symptoms and create that unique treatment program for you. You hear, oh, my auntie had this, they did this to her. It might not be what you need. And that's why we really have to go through our different exams, and we look at your eye movement, your head movement, your balance, your strength. We look at all those different parts of you to see what your needs are as we create your specific exercise program. It's not a one size fits all. And again, treatment depends on the cause of your dizziness. Oh, I wrote that at the bottom. All right. So common peripheral disorders, you've already heard these. I won't go a long time on those. Benign positional vertigo, vestibular neuritis, labyrinthitis, Meniere's, vestibular migraine. But here, in the one part that a lot of people ask and a lot of people come in, I think I have this, which many people do. It is one of the most common forms of vertigo, but not everybody has it. It's that benign positional vertigo. It's where the calcium carbonate crystals that are naturally in the inner ear that help with the movement, the gravitational pull of the flow of the fluid. You can see that spinning there as someone tilts their head up or leans backward. We will show you how to do it tonight, but there are 3 canals in each ear, and the most common is the posterior canal. That's kind of like when I look up to put in eye drops or I roll over in bed, the room spins, but it might be one of the other canals also. You have a horizontal canal, and then not as frequently in the anterior canal. So it is important to know which canal and which ear so that you're not spinning the wrong one, which would only just make you feel worse. Or what a lot of people do is because they start the maneuver, which happens to be the testing position, the Dix-Hallpike, they don't like it and they feel sick. So you just shook up your snow globe and you sat up and you didn't finish it, and you just made yourself feel worse, right? So you just want to be careful. Just because Susan down the street had it doesn't mean you have it, right? The sensation that severe room spinning dizziness, duration, it can last like seconds. It feels like hours, but it can be seconds. Again, rolling over in bed, looking up, bending down, and then we do the repositioning maneuver. The Epley is the most common, or also the Canalith repositioning maneuver, but there are many other maneuvers too. It's not just that one. It's finding the one that works for you. And that's kind of our job. I talked about the systems that maintain your balance, your vision, your inner ear, and your proprioception or movement in space, which also includes muscle strength, right? If you don't have that muscle strength, you're not going to have as good a balance. And as we, again, move on in life, we tend to lose muscle strength, and we have to work to keep it as opposed to maybe even building strength, just even maintaining it. So you see how they work together. You have your brain, which your motor command creates your movements, your sensory information going up through, and that balance just keeps going. And they have to all work together. And we have to help ourselves work those together. Intrinsic risk of falls, which, that's the F word for most of us. We're pretty scared of those. My husband made me change it to senior years instead of advancing age. That's not nice, he said. It was all right, our senior years. Previous falls or fear of falling, once someone falls, they can be gripped with fear and not want to move again because of that fear of falling, right? I'm sure you've had friends that have had that. People start shuffling their feet because they think if their feet are touching the ground, they're less likely to fall. And that's a slippery slope. It just keeps going and going. Muscle weakness, it's huge. It's a big, big part of balance issues. I know we're talking a lot about vertigo, but these all go together. It's not just vertigo. It's vertigo, it's balance, it's dizziness. It's all about being steady, right? We talked about vestibular dysfunction, gait and balance problems, walking and balance problems, poor vision, postural hypertension, right? People who get out of bed quickly and they feel lightheaded and they 3 steps and they're on the floor walking to the bathroom. And the doctors talked about some of the chronic conditions. Extrinsic risk factors for falling, right? Lack of stair rails, or stair handrails, poor stair design, lack of bathroom grab bars, dim lighting or glare, right? Obstacles or tripping hazards. How many times you hear about people tripping over throw rugs? Slippery or uneven surfaces, that's terrible. I had a friend who just got back from France, and she walked into the beautiful hotel shower and it was too slick and she went down and she fractured C4-5 and had to have surgery in France. I mean, who would know, right? This woman golfs and she's super active. You just have to be aware all the time. Her husband said, why didn't you put something on the shower floor to help? You know, hindsight is 20/20. But if those little things, if you're looking more at prevention, it makes a big difference. Medications can be a risk for falling. They can cause dizziness. They can cause all kinds of issues that make you more unsteady. And of course, improper use of assistive devices. How many times do you have friends, I'm not looking at you, with a walker and it's pushed 2 feet out in front of them and they're bent over, right? You see that all the time. I wasn't looking at you. Visual impairment, right? You think you're having visual issues, that can absolutely affect your balance too. And then that's, of course, increasing your risk of hip fractures. Neuropathy, that's part, then we take that into that balance mechanism of proprioception or your awareness of movement. You know, you hear people talk about neuropathy. There's so many different reasons people can have neuropathy. But when we look at, as therapists, how does that affect your feeling your feet on the floor? Or pain with stepping, anything like that. And that's part of that whole balance mechanism and how those systems work together. Muscle weakness. This is huge. Women over 50, men over 60, what happens? We start losing our hormones, right? We start losing our muscle mass. We have to work to keep it. And how many of us retire and end up sitting on the couch or sitting at the computer too long during the day without getting up and doing something, right? It's super important to keep your muscles strong. Muscle cells become replaced with fat and connective tissue, sarcopenia, inside the muscles themselves. And we find that fat accumulation in the muscles is associated with weakness, poor function, and mobility limitations. The old use it or lose it is 100% correct, especially for balance. And if you're balanced, you're probably going to help your vestibular system because you're going to be stronger physically. Being able to keep going with the physical activity that Dr. Gertel talked about, right? As you're getting over your vestibular issues. Talk to your doctor, home modifications, vestibular therapy, and regular exercise. Balance and fall prevention. Dizziness is a major contributor to falls. You're twice as likely to fall if you have dizziness. Falling once doubles your chance of falling again, which leads to anxiety, social withdrawal, inactivity, and reduced quality of life. And we all know people that's happened to, right? And we don't want to be those people. And dizziness and falls are not a normal part of aging. We should be able to be super active and stay there. Talk to your doctor, right? Talk about your physicals. Talk about the dizziness you're experiencing, falls or fear of falling. Try to be specific. Review your medications, and you can always ask for a referral for vestibular rehab with a PT. Talking about making your home safer, trip hazards, right? The rugs, not having something on the floor of the shower, the non-slip bath mats, having proper lighting, night lights, grab bars, having good footwear. Nothing worse than slippers that you don't have a back and you just see people shuffling, right? Regular exercise, super, super important. We should be walking. And if you can't walk, ride a stationary bike. If you can't ride a stationary bike, try to swim. You got to be doing something. 30 minutes of exercise, 5+ days a week. Doesn't have to be 30 minutes at once, but you should be active. If you can't get out as much, you can't do things, get up and walk around in the inside of your house. Just be doing something. But the nice thing about being outside and walking is you're on unsteady surfaces. You're on environmental surfaces, which trains your body to be able to handle most activities you're going to be going out and doing. Start small, build up, join a group or community exercise. Silver sneakers programs, if you have with your supplement to Medicare or the TMIPA program, right? A lot of them have the silver sneakers. And of course, as Tim, our therapist, says, the best exercises are the ones you'll do. Posture is super important. Posture, posture, posture. I think that's going to be on my headstone one day. A long time from now, I'm hoping. Good posture is everything. If you're standing up straight, it supports your health and well-being, your balance, your stability, improved breathing, more efficient movement, mental focus. Poor posture can lead to imbalance and risk of falls. And then it leads to shuffling your feet. And then it leads to fears of falling. And then it leads to, I feel dizzy when I'm standing up, but maybe that's not really dizziness. Maybe that's imbalance. That whole thing I talked to you about before. I just see it so often. Okay, so now we have my father. He's going to demonstrate exercises. Let's see if I can get this right here, right, Kevin? Will it go if I do it? Yeah, there we go. I put together some exercises on videos. You have handouts on the exercises. These are just straight leg raises. These are great exercises to help keep the strength in your legs. This man golfs 2 to 3 days a week. And clams, another good exercise, helps keep your hip rotators nice and strong. These are just easy things you can do at home. Sit to stand. There you go. You can do it when you're getting up from a meal, right? 3 or 4 times. So you've done it now 3 times a day. Just working on keeping that nice strength. That's like doing squats. Single leg stand, you can do it after you brush your teeth, morning and night, just working on single leg balance. Very, very important. Hip abduction, kicking your leg out to the side, works your glute muscles, right? Having nice, strong glutes certainly helps your balance. Hip extension, kicking backward, keeping that buttock nice and strong. You can do some weight bearing to the side, which then eventually leads to progressing to side steps. Looks like he's going to dance. Right? A nice calf stretch. People's calves get pretty tight. I like this calf stretch. It's a nice way to just kind of loosen them up a little bit. You can do that standing in the kitchen, putting your foot against the cabinet. And then a seated hamstring stretch. Hamstrings get really tight from sitting for long periods. Just a nice little easy way to bend forward and stretch them out. So some of the goals of vestibular rehab, trying to resolve, for one thing, the positional vertigo, if that's what you have, the benign positional vertigo, which we'll go through that maneuver today. Reduce your dizziness and fall risk. Improve static and dynamic balance, improve visual disturbances with head movements. Like if I'm in the grocery store and I'm walking and I turn to look at something, I might feel dizzy. Sometimes the eyes beat a little bit. Those are some of the exercises that we establish for you in therapy when we see what your needs are through the evaluation process. Overall physical fitness is important, increasing your independence, increased participation in social activities, super important. Improve overall function and quality of life. A vestibular eval, history, that's huge. We need to know your history. And we'll do a neck screen just to see what your mobility of your neck is like. Eye exam, we're looking at nystagmus, which is the darting of the eyes. Those are specific things we're looking for with certain head movements and eye movements. A neurologic exam, not that we're doing what neurologists do, but we're looking to kind of check things if maybe they're central or peripheral reasons. Balance testing, BPPV testing, which we're going to look at, the Dix-Hallpike. We use the models to help, and of course, always a home exercise program. How to get vestibular rehab? You can find a clinic with a vestibular therapist at vestibular.org. You can talk to your doctor. Here at Torrance Memorial, we have 4 different vestibular therapists. We are happy to help you. Everyone is well-trained and has done certification programs, but you do need a referral from a doctor for a hospital-based therapy. In summary, accurate history is super important. Know the difference between vertigo, spinning, I'm feeling lightheaded, or am I unsteady, right? Because those are things you can tell your doctors. You may not be able to tell the difference. That's kind of up to us to figure that out too. But it helps when you can get an understanding to be a little more specific. Tell your doctor if you're experiencing dizziness, and vestibular rehab is an important part of recovery, and the treatment truly depends on the cause of your dizziness. It's not a one-stop shop. Thank you.
Will I see you? I was wondering if we should use the table.
Oh.
She's not gonna do it on the floor.
Yeah.
Use the table, right?
Yeah. Thank you, Noelle. So we're just going to demonstrate an Epley maneuver, and just disclaimer, please see your doctor to get evaluated and work with the appropriate specialist, because we want to make sure that we're treating you for the appropriate condition. I think just in the context of everything we've talked about today, it would be nice to at least see how it's done, so you can at least kind of be aware, but this is not something we would recommend to do at home without guidance from a physician or a physical therapist.
Okay. I know. You can all hear me, right? I have never been accused of being too quiet. You can scoot way back. We don't have a pillow. So we're just going to assume it's the doctor's left ear, right? And the first position of the Epley maneuver is the test for it, all right? So normally we'll have them on the bed. I'll have a pillow, so it's a little bit thicker behind her shoulder blades. And I'm gonna have her turn her head about 45 degrees to the left, and I'm gonna come on back. So we'll just kind of have her head back. I'm not gonna crank her too far back, because I haven't assessed her neck to make sure she's good. But what I would look for in this position is nystagmus, for movement of the eyes. Right? Normally I would have her back a little more, but I'm not gonna crank her head back really far, because I don't know if it's okay to do that. I would stay here 15 to 20 seconds. That's usually when the dizziness would start. You'll see a spinning of the eyes. You would feel the room spinning, and usually want to get up, right? But that's where we don't let you get up. We wait until the dizziness stops, and then pretty much count to 30, so it's about a minute total. And then I would take her head and I would turn her 45 degrees to the right, still watching her eyes. Usually this second position, they don't have too much going on. It's usually most of the first and the third, right? And then, so she's been here about a minute, we're gonna say. So now she's gonna tuck her chin. You're gonna roll onto your right side for me. Just be careful scooting over there. And I'm tucking her chin down so that she's looking 45 degrees to the ground with her chin tucked. Again, we're waiting about 30 seconds after the dizziness stops. So it's been about a minute. So she's gonna keep her chin tucked into her shoulder. Go ahead and come on up into sitting, keeping that chin tucked in on that right. Bring your legs up. And then she can sit up straight. And here, sometimes people feel like a quick spin, like someone pulled the rug underneath them. And we just sit and wait till she feels better. Right? That's for the left ear. We always roll away from the ear that it's in. And I wouldn't turn around and do her right ear, because we're saying it's in her left ear, so I wouldn't do it backward. Right? Does that help? Okay, thank you. Thank you. All right, that's it.
All right. Thank you so much, Noelle, for your patience with me for going off script tonight. But I think that was really helpful for everyone to see. I do see a question back there. I think let me just we'll do a quick 5-minute break, and then we'll have you write down your questions, and then we'll reconvene. It's 7:50, so we're kind of cutting it close. So maybe at 7:55, we'll do a few questions.
Yeah, people are dumping them up here, and I want to make sure you get them. You got a pile to work with there. We can get back out to get cookies.
Okay, are we ready to reconvene to answer some questions? Hello, for those in the back, if you want to participate in the questions, we're going to be starting soon. Okay, for the interest of time, I'm just going to go ahead and get started so you all can get back to your restful evening. I think there was somebody in the back who had their hand raised. I don't know if she's still here because I did want to get her question addressed, so she might not be here anymore. Okay, so the first question that I have is, what does it mean if the vertigo gets severe or gets worse for several hours after the Epley maneuver is done?
It's not uncommon to have the vertigo be worse after the Epley maneuver. It's kind of, you're shaking your snow globe up, so you're going to feel it for a little while afterward. Maybe a day or so. I tell people it's kind of like having the flu. So that's not unusual. Now, if it's days after, that might be a little bit different, but a day or so is not unusual.
And can you have the crystals out of order in both ears at the same time?
Yes, yeah. So that can affect both ears at the same time. Again, with that type of vertigo, so more than 90% of the time, we don't really know what causes it, but it is certainly possible to have both sides. The 10% of the time that people have that type of vertigo, the positional vertigo, can be related to head trauma. So if someone hits their head hard enough, then that can knock the crystals out of place in one ear or both ears. So it is possible, and it is also possible to treat both ears.
Okay, so the next question I think is kind of interesting because this does come up in my clinic occasionally. Can spinal stenosis cause balance problems?
So I think this is a situation where a lot of neurologists kind of start to pick hairs a little bit. I would say that theoretically, if there is like high enough spinal canal stenosis, you may have like disruption of a little bit of a kind of different parts of the areas of the brain that might be affected. So sometimes people will say, really, if you're having issues with like the lower brainstem and cerebellum, then certainly you can have a little bit of issues with that too.
Thank you. And then for this question regarding BPPV, this person wrote, I've had BPPV recently and it was a long wait to see a physical therapist. Is there anything I can do at home to alleviate the symptoms while I wait? It's a tough one because it is sometimes a long wait.
Yes, unfortunately, that's true. It's everywhere now. Try to get an electrician, right? You just have to kind of know what ear. I mean, these maneuvers are on YouTube, right? You can do everything. I can fix my dishwasher on YouTube. It really just depends on which ear and which canal. If you're confident enough, you know what side it is. You certainly can try the maneuver, but it is hard. I know it's hard to get in. I'm sorry about that.
And a lot of people can tell you might be able to tell what side is on. It's so if you turn your head or the movement toward the affected side. So if that, like when you're laying down, if you roll over to your right, and that's where you get the dizziness. So it's your right ear that's the problem. And so there are simple ways to tell which ear it is. And so if you're confident about doing it, and you want to try it, go ahead. I mean, if you do it wrong, I mean, you're not going to cause any permanent damage and so it's not like dangerous in that way. It's just, maybe it could temporarily at least make things worse for a while.
Right, and I would finish it. If you're going to start it, finish it. Don't just start it and pull out of it because you just shook it up.
Is there a way to get rid of tinnitus, which is ringing in the ears, especially for those who've had it for a long time? I think this person had it for like 10 years.
I mean, that truly is the billion or more dollar question. Right now, we really do not have a cure for tinnitus. I mean, really the main problem is we don't fully understand what causes it in the first place. And so there are thoughts that maybe it's coming from the ear itself, maybe it's coming from the brain, and there are abnormal signals either in the ear or the brain, but we really haven't proven what causes it in the first place. And therefore, we really don't have a true cure for it. And so, I mean, there really aren't any medications, vitamins that like our ENT Academy recommends. Sometimes, like working with a psychologist and doing cognitive behavioral therapy can be helpful. It's not going to get rid of it, but it can help you kind of live with it better. There are some newer devices coming out into the market that work with either stimulation of the wrist or the tongue while you're listening to certain tones, and it's supposed to condition your mind. And so those things are promising, but not enough information out there about it. If someone did also have hearing loss, while wearing hearing aids, that can temporarily, at least while wearing the hearing aids, can help the tinnitus. In fact, that's really the only real intervention that our ENT Academy recommends, is that if there's hearing loss, hearing aids can help. But it's a very tough problem, and it's very difficult for me. Obviously, for patients, it's difficult because you guys are the ones experiencing it. But I'm used to having, okay, if you have this problem, we can treat it. Tinnitus is kind of like the one thing in our ENT world that we really don't have a cure. And I suspect that there's probably a lot of something in every specialty, but tinnitus is really a tough one. So if someone comes up with a cure, definitely more than $1 billion idea.
I agree. This is kind of a similar issue that we face in primary care as well. So if you all want to donate some money into research for this, for a treatment, that would be very helpful. Okay, so this is also a good one. I also hear this occasionally. Can the COVID vaccine cause disequilibrium?
Well, I mean, anecdotally, I mean, I have seen patients both with after the vaccine, certainly after COVID itself, that have reported, dizzy symptoms to me. I don't fully know what the most recent, research or conclusions are about that. But I mean, I think not just the COVID vaccine, but I would say any vaccine which is causing this strong immune response can certainly lead to, our inflammatory response can certainly lead to an inflammatory condition of the inner ear, the balance nerves. So I think that even before there was the COVID vaccine, we were aware that vaccines in general can cause, can cause dizziness. As far as is it specific to the COVID-19 vaccine, I don't think there's necessarily the data out there that says that it's specific or it's more common with that vaccine. But so I think it's certainly possible that it can cause that, but I don't know if it's more than any other vaccine.
Okay, I think we have time for one more question, and I'm going to combine two of them for efficiency. So is it possible to have BPPV and there not be any movement in the eyes? And if there is movement, does the person know? Are they aware?
So for the first question, it's possible. I mean, everyone's different. Not everybody has the same exact symptoms. Sometimes things present abnormally or not in the classic way. And so if we do the exercise or you're doing movements and you feel the room spinning, then yeah, it's possible you won't have these eye movements. And then the second part of the question.
Does the person know that they're having nystagmus?
Oftentimes, no. I mean, sometimes you will notice like, oh, everything's kind of bouncing, but a lot of times, no, you won't even notice it. And people are surprised whenever I test this in the office and I kind of lay the person back into that first part of that exercise to stimulate the vertigo, I tell keep your eyes open, because I'm looking at your eye, and most people don't understand why. And I say, oh, your eyes are bouncing back and forth, and they're surprised. So not necessarily will you notice it.
Okay. Well, thank you so much to our specialists for making it out tonight. I definitely learned a lot from you all. And thank you guys all for coming, with the cold outside, so definitely drive safe, and we will see you next month for our next lecture. Thank you.